So this next session, while everyone gets settled on stage, is called I was yelling at people not to talk into their mics, and here I'm not doing it. It's a healthcare coup, and technology is the culprit. The concept was there are some profound technologies and practices being developed right now, and we're really excited to hear not only the challenges but the advice of experts that they are providing to new companies. So we've brought two incredible companies together that are doing amazing things, and also two individuals that are looked at for advice on a number of things, all the way from design to FDA approval. So, and I was fortunate to get Dr. Pierre Theodore to accept to moderate this session. Okay, how do I should have read this before. Van Auken, is that how it's pronounced? Van Auken? Okay, sorry. Van Auken Endowed Chair Associate Professor at UCSF Medical Center, which is my hometown, so I'm kind of excited about that. So his motto, if the wind will not serve, take to the oars. Have a great session.
Thank you, Jill. Thank you very much for the introduction. And I want to just introduce myself for a little bit and my overall view of the space of digital health care and health informatics, perhaps more broadly speaking. And so I guess there's this saying sometimes that people won't remember exactly what you say, but they'll remember how you make them feel. And I'm assuming since it's lunch, you're going to feel satiated and nourished and full by the time we're done the session. So, I'm a cardiothoracic surgeon at UCSF Medical Center, so that means I spend the vast majority of my time taking care of lung cancer patients, esophageal cancer patients, working on the heart and the lung transplantation service. And that leaves relatively little time for device development. And so it might seem at first glance like a sort of an odd position to be so highly stimulated to look for digital tools to help to advance healthcare. But at the same time, and in fact, some people sometimes think, well, it must be because you're in San Francisco and you're exposed to a large number of tech giants. And those tech giants do certainly provide plenty of mentors and plenty of excellent thinkers to help guide and sort of shape our views of digital healthcare. But I would say that really the motivation comes from being in the operating theater day to day and seeing technologies that often one might even consider that are actually insufficient. We look around and we see certain technologies used by our own teenagers which are superior to those that we use to communicate in healthcare, and wonder why we can't bring to bear some of these superior technologies to the most important and most important domains that I can think of, which is maintaining and supporting human health. I like to think of a small anecdote. We created a company that created a web-based environment to allow physicians to collaborate in a multidisciplinary fashion so that multiple physicians could bear on the care of a single patient. I thought I was quite proud of myself in telling one of my patients who was 78 years old that we have a secure web-based environment where we're going to upload the content of the electronic medical record. Multiple physicians will be brought in to review your CT scans and your pathology reports. They will venture opinions about your care, and we will come to a common treatment plan. And I told her this with certain kind of a pride in my voice about what I had created, quote unquote, at UCSF. And at 78, she looked at me and she said, "You mean you don't already do that?" And the implication was that there's a certain expectation for our ability to collaborate. I think to some degree we may be letting our patients down. So, I think one of the key questions for me is to ask the following, is to consider what sorts of technologies do I, as a clinician, feel will have the most major impact in day-to-day practice. So what we've done is we have four, at least at UCSF under my sort of watch, if you will, we have four principal programs that we're trying to get off the ground. The first is as I mentioned, the collaborative framework for multidisciplinary care. The second is applying optical wearable head-mounted technologies in the operating theater. Probably the most evident example of that would be using the Google Glass in the operating theater, where we completed the first internal review board series of patients, which will be shortly in the academic literature. We have, in addition to this, begun to use wearable technologies for patients with early cognitive decline as a means of keeping them from requiring dependent care as they age. And the issue that to me is most dear to my heart is using low-cost networking technologies in the developing world to offset disparities among the globe's poorest patients. So I think some of the work that we see here that's obviously so advanced, bionics and many of the wearable technologies, at some point I would hope will diffuse throughout the world to offset, as I mentioned, many of these disparities. So with that as a backdrop, I am actually very delighted about the panel that's in front of you right now. And the reason is because they're very complementary. We're going to talk about the development process from the perspective of software engineering and considering user experience. We'll talk about a little bit from the hardware perspective and what it is to get hardware through FDA regulatory hurdles and the like. And that market division between what you might call sort of a consumer-facing project and projects that grow up within an academic medical center that are more going down the line towards enterprise applications and require more robust regulatory hurdles to come to adoption. And then we're going to talk a little bit about how companies actually fuse those prospects of software development, hardware development, in a manner that actually drives down healthcare costs, which in some ways I suppose is the holy grail for almost everything that we're talking about during the sessions over the last couple of days. And then finally, we can sum up by really maybe bringing this together as in terms of a portal that will allow for the patients themselves to discuss specifically with clinicians. You heard a little bit of this earlier with Dr. Storch. And we can talk a little bit about what can be lost when physicians communicate with patients in web-based environments, and that, if you will, high-tech and low-touch part ends up losing parts of the hospital, of the doctor-to-patient relationship. So to kind of get right to it, I just want to make a brief introduction to our panelists, and then I'd prefer that they tell us a little bit about what they do day in and day out and their general approach, and then we'll have some questions among them that will help to kind of direct the conversation. So directly to my left is Amy Cueva. Amy is at MadPow. Largely, Amy's corporation is devoted to refining user experience, doing sort of a comprehensive evaluation of how customers, patients will use software solutions, and I'm sure she'll go into significant more detail. Directly to her left is Jeff Goldberg. Jeff excuse me, is Jeff Goldberg. And Jeff is, Jeff, I'm sorry, tell me the name of your corporation again so I can.
Ideal Life.
Jeff is at Ideal Life. And what I'm so impressed about Ideal Life when I was reviewing some of the work earlier was that they've actually managed to do some implementation that really has shown some incredible economic benefits. So I'm looking forward to hearing a little bit more about the specific benefits that he showed in the past. And then to his left is Hector. Hector is going to tell us a little bit about, if you will, sort of from MD Live, a little bit about a higher tech and sort of a lower touch approach, which allows the physicians to, or the patients to directly communicate with physicians. And then finally, at the far left is Aidan Petrie. And Aidan is from Zymedica. Zymedica is a consulting firm largely that helps companies that are in the device space to navigate the regulatory hurdles. So with that said, let's turn a little bit to Amy. Amy, you have something for us today, and I'd like you to discuss a little bit about what you do in this space.
Sure. Hi, everybody. I'm Amy Cueva, one of the founders at MadPow, Chief Experience Officer. At MadPow, we seek to improve the human experience, leveraging design and technology. And our core philosophy is to involve the people who will be affected by the solutions we create in the process of creating them, and to definitely consider the health outcomes, but to consider also the life outcomes. How can your product or your service bring a smile to somebody's face? How can it change their lives? How can it get them to call their mother? How can it get them to jump up and down and truly enjoy and derive meaning and value? We try to get to the core of that. And you guys have been hearing, sitting is the new smoking, and it's about mood tracking and mood enhancement, and how do we connect all this together? So I'd like to do a little mood enhancement, if you'd allow me to do so. So I'm hoping we can all get up out of our seat, smile, raise our hands above our heads, stretch, kind of a seventh inning stretch, and shake the hand of the person next to you. Introduce yourself, first name only, and then you can kind of move from there.
Nice to meet you.
Nice to meet you.
Here.
Nice to meet you.
Nice to meet you. Thank you.
No problem.
All right.
We can do this whole thing standing if you guys want. No, I'm just kidding. That's me. Nice to meet you guys.
All right. Jason, why don't we turn our attention to you for a second? We've talked a little bit about this before, that really Idea Life has approached some of the really big ticket items in healthcare, and by that I mean congestive heart failure, diabetes, hypertension, with kind of comprehensive service, combining software and hardware solutions. Can you tell us a little bit about, number one, sort of just a general approach of your company, but I think beyond that, if you can talk about the sort of metrics that you use and you place out there to sort of demonstrate success.
Yeah, no, pleasure. Thanks for having me on the panel. I think having this panel after the last, I think, and definitely Jill knows how to conduct the conversation and the discussion quite well, lay the foundation. I think one important thing that many people keep missing, and we still ask questions, what's going to happen in the future? What are the goals? How can we make all this stuff work? I think Leslie asked a number of good, tough questions in the last panel around cost. We have all this cool stuff. What do we do with it? Really, our approach to the space was leveraging information technologies in a new, innovative way, knowing that healthcare is moving out of the institutional setting. And a lot of these conversations are happening. A lot of things are going on in between the physician-patient visit, the calls that happen between case managers and clinicians with individual patients. A lot of things are happening outside of the institutional setting. How can we harness the power of all that data, the self-assembly of the personal health record, if you will, and further empower caregivers? From our perspective, it's many clinicians, physicians, nurses, case managers that are remotely monitoring or dealing with patients and health consumers, or family members looking after loved ones. How can we harness the power of that information and further empower the caregivers to deploy the right strategies around health management when someone is in congestive heart failure, diagnosed with diabetes, hypertension? And I think most importantly, around empowering the individual with the right information, education to take the next step and deal with their health strategies. So for us, it was about what we do at ID Life is we've delivered a technology platform around gathering all this information around from ID Life products as well as third-party products, leveraging that data, wirelessly communicating it remotely, and making it available to all individuals across the entire care continuum.
Can you comment a little bit about using the family members themselves as sort of part of the caregiving process? We saw that really remarkable use case earlier where the patient ended up with some severe bradycardia with a heart rate in the 20s and was really rescued by these the devices in the house and the communication of the data. But I think many people are intrigued by the idea that family members themselves also participate in the healthcare, and I'd be curious how your system interfaces with, if you will, non-clinician caregivers.
Yeah, and to take a step back from that, I think first and foremost, one of the, I founded the company really for selfish reasons, out of watching my parents deal with the struggles of my grandparents' growing conditions and issues. And although our family was maybe a little bit more geographically dispersed than most, I think most families today have that issue. And it was really designed with the hope around dealing with the caregiver's burden. And what do we do? How can we become more active participants with those patients, our loved ones, in dealing with those aging issues? For us, it really starts with that trusted relationship that the individual or the family has as the real patient advocate with the healthcare facility and institution. And what I mean by that is our technology platform is delivered from the institutional setting, the hospital system. And Mr. Tyson, for those of you that were able to hear the story, was a great example of a independent delivery network, a wonderful hospital system that has a wonderful staff that have delivered a hospital discharge program to an individual that was in the hospital with an issue, left the hospital, and one of the comments were in the future, maybe doctors will prescribe the technology as part of the care plan. The future is today, it's happening today, and that's what I think is missed a lot here. That small program has grown, and some of the recent data we've had from that project has shown incredible savings for the hospital, but most importantly, life outcomes with Mr. Tyson. So starting with the institutional setting as really the fabric of delivering the technology solution in the hands of the patient, having a wonderful skilled trained staff in delivering the program really is the start. And then the family members have access to that information on demand if they so choose. And we're seeing more and more family members interact when they go to the hospital, not with the spreadsheets of all the information, but wonderfully architected, meaningful information presented in a nice graphical way when it's useful to the individual patient and for the physician to interact together and really drive those outcomes.
Chuck, you know, in some ways, similarly with MD Live, I suppose the ultimate example of involving the family members in the care of the patient is really, as was pointed out, I think one of the films of use case for MD Live is where the actual family member, in that case a mother or a parent, is actually contacting a doctor through a portal. And I was wondering if you could comment a little bit about the effectiveness of that sort of interaction and sort of what kind of data you've been able to accumulate that really shows that the kinds of interactions that you're having through these sort of telecommunication-like events are roughly similar to what the patient or the family would be likely to experience if they were to go to an actual hospital or see an actual physician.
Absolutely, thanks, Pierre. You know, there's a doctor shortage upon us right now, and it's going to get only worse. Entering medical school is less desirable now than it has been for 2 decades, and those that are entering medical school are heading into specialty care, not heading into family practice. So there's a shortage, it's going to get worse. So for a mother with a child who needs access to an ear, nose, and throat physician or a pediatrician, sometimes these people are not readily available unless you go into an emergency room. And an emergency room is the most expensive place you can access health care currently in the United States. So telehealth becomes an interesting alternative to that same mother who can access a network potentially and find a dermatologist or a specialist. It's nearly impossible to get a same-day appointment with a dermatologist unless you have a friend who's a doctor in today's current status. So that mother can now go in and find that specialist, have an appointment guaranteed in 1 hour, and do that consultation privately from their home through video. It's fully secure, and have a great outcome, inclusive of a prescription if it's medically appropriate. So we have been in business for almost 8 years now, and have a mountain of evidence and testimonials that show that telehealth reduces costs and increases access.
And do you have any worries about any liability issues per se when direct medical advice is being given via telecommunications platform without actually having physical contact with the patient? Does that ever raise an issue for you or your group?
So, half of our company is like a very large physicians association. So we have 10 physicians on staff and over 3,000 in our network nationally. So of course we adhere to clinical guidelines very carefully and very meticulously. We're in a constant review of all of our clinical work. So there's always a concern, but I think what we have done pretty effectively is we have made the decision early on as to what telehealth is appropriate for and what it is not. Jason can't call us with abdominal pain and receive treatment. Our system and our physicians would not allow that and probably call 911 for Jason. But we communicate very effectively that the service is for low acuity symptoms, cold and flu, headache, migraine, headache, skin irritations, and things like that can be easily addressed and therein so doing alleviate some of the overcrowding in the emergency rooms. And the hospitals, many of whom are our clients, do not want that overcrowding. They don't want the people overly consuming the emergency room for low acuity conditions that can be resolved through telehealth in a safe and secure HIPAA compliant manner.
Thank you. Aidan, maybe we can turn our attention to you for a moment here and sort of take a step back really and talk about the earlier stages in device development. And your company obviously has a tremendous amount of experience in helping early stage, and I would imagine along a whole array of stages, companies navigate this relatively complicated and changing landscape that is FDA regulation. And I was wondering if you could just comment just kind of broad strokes about the process as you see it, and then maybe particularly for those of us who are involved in earlier stage projects, think about what are some of the more common themes of pitfalls that you've run into with early stage companies, the way they visualize the space of regulation, when they get to that point where they're deciding is this going to be more of a consumer-facing, if you will, product for the healthy, or is this really going to be a medical device for ill patients?
Sure. Well, Zymedica's role is very much to deburden somebody with a technology from the costs of having to do all of those steps. Essentially, we're a quality management system that you hire rather than build it yourself. So we see an awful lot of different technologies. And in the determination, the FDA has a very particular view of what a medical product is. So the first step that people get confused about is whether they are medical or they're not. And it's one of the places where the FDA is quite brief. It's if you're diagnosing a medical condition or you are mitigating a medical condition, then you are a medical product. And it's for humans and animals, interestingly. And so I think in the sort of under the umbrella of this discussion, we meet a lot of folk out of universities and labs that have really, really clever technologies that would be really useful if employed, deployed into the populace. The thing that with a medical product is it's generally being paid for in a couple of different ways. It's either being paid for via an insurance, a reimbursement set of codes, or it is going to have a savings to a hospital. And so there is and allow a hospital to operate more efficiently or so forth. So like a rapid diagnostic. And a lot of times that value proposition, it just being clinically useful and possible to do as an enabling technology and as a use, isn't really enough for a medical device. It has to have a value, and hospitals are super burdened. Insurance companies are looking for ways to cut costs. So having enough understanding of where the money flow is within the medical industry, I think, is really important. And so what you get tripped up by typically is a rabid enthusiasm, where the sort of the motivator that everybody wants to get well appears to be a good thing, but it isn't often borne out by people's behavior. Mm-hmm. And so really understanding how to put a product into the people's lifestyles and fit in is where I think is something that has to be considered. And a very simple example is there was a rash of devices a while ago that were coming forth looking at skin cancer. And we were hired a number of times. We went out, we did consumer studies, and the consumer said, boy, we'd really like to have an app that could tell me if this little thingy was doing something it shouldn't. So from a marketing side, the market was there, the market was interested. But when you went to the docs or the people who were going to have to do a diagnosis on that, there was a very different set of questions. How specific is it? Who's going to pay me for it? How am I going to access it? And so forth. So understanding the full ecosystem of the medical field, mm-hmm. I think is important to be really successful in this business.
Sure. Amy, that in a way seems to dovetail a little bit with your company's philosophy, and I thought maybe you could comment a little bit about really how you turn to the potential consumers down the line early in the process to really get this kind of an iterative process where you're getting constant feedback during the sort of development process for digital technologies and apps. And I was wondering if you could just comment a little bit about how you, if you will, involve the consumers into the very development process itself.
Right, absolutely. So speed is always a factor. Everybody wants to, get it to market as fast as possible. Of course, that's essential, but speed can make us forget, very important things. So, for example, we skimp on research. We wait till the last minute to start the design. We rush toward validation. We show it to our brother and think that that's good enough. That sort of thing. So what we recommend is early and often put pen to paper as soon as you possibly can. Start designing the experience, and also forget everything you know or everything you think you know. Be a student of your target audience. Observe them. talk with them. In order to be fast, we make assumptions, and that's necessary. But some of those assumptions can come back and get us later. So it's really important to observe the people who will be using your product in their native habitat, if you will. Observe their workflow. Who are they talking with? Who's important? What are the obstacles? What are the challenges? What are the dependencies? And again, what is the true meaning and value that they're going to derive from your experience? Is it one of delight? Is it one of accomplishment? And how will that actually happen? So that foundational research, not focus groups, observation and talking with people, and then leveraging participatory design methods. So inviting your target audience to the table to design with you, involving them in collaborative design workshops, and then showing them prototypes, having them bang away at it. And we'll look at usability. Can this person get through this form, or can they see the information we want them to see? That's important. But we also do things like usefulness testing. Just because it's easy to use doesn't mean that I will use it. And again, getting at that real value. Are we delivering that real value in a way that's going to drive use and engagement? Another thing that we think is really important is collaboration inside the organization and outside of the organization. So who inside the organization has a stake in this? Who knows the customer? Is it the sales team? Is it the call center associates? Is it the doctors that treat those patients? So really getting a bird's eye view of inside your company and outside your company, the ecosystem within which this product will play. What other organizations have shared objectives? If you're in heart health, who else is working in heart health? What existing content and assets and data can be leveraged, can be pulled in? What kind of partnerships or programs or services can be combined? Because what's happening a lot now is that we're reinventing the wheel all over the place. We're all doing amazing, innovative things, but I think there's power in connection and coming together and seeing where we can pair up and do things together.
That's well put. Jason, do you want to comment at all about the use of sort of multiple devices at one time in the outpatient setting? And in specific, if you could draw on any specific examples in which the use, we've talked about some individual use cases, anecdotes effectively, but where in a medical system you've really been able to show some value, decrease costs as a consequence of really placing these kind of systems in the home. Can you speak to that directly?
Yeah, and I think it extends to what Amy's talking about, and definitely the one piece that we need to shed a lot of light on that Aidan was mentioning is the value proposition and the business model. There are a lot of technology folks here, and we're seeing a lot of great things on the floor and continue to see. The one problem is effectively what is not only the usability and the life use of the product, but as far as the business model that we can deploy to get critical mass with regards to adoption of all these wonderful technologies and working together. And I think it's very critical to interact with the customers on not only price elasticity, but also effectively how it will be deployed and what's the model, especially in healthcare. Oftentimes you have the payer that is not the user of your product. So it's very important to understand ease of use, ease of deployment as far as a strategy with regards to health consumers using your product, as well as what's the model for the institution, the healthcare provider. In the case before that we're talking about Mr. Tyson's healthcare facility, Vidant Health in rural North Carolina, a wonderful large hospital system. What is the value for them to deploy these programs? And we're not talking about small projects, 30, 50, 100, a few hundred lives. One of the smaller programs that we have, but at least significant impact for Vidant was well over 1,000 patient program of individuals using multiple devices. And multiple devices is because appropriate to what? What is the goal and objective of the institution? It's to, in the case of Vidant Healthcare, who effectively is the customer, it was for them to better manage their costs with regards to penalties coming down the pike for patient readmissions, and looking at very specifically what types of patients, those that are high-frequency users of the hospital and coming back, revolving door issues, people with congestive heart failure that oftentimes need to be monitored for their weight, sometimes oxygen saturation, definitely blood pressure and heart rate. So it really starts with what is the goal and objective for the healthcare facility or organization provider. What are their goals and objectives? And they're often looking to deliver a comprehensive solution with a partner that'll help them get there and scale the program. They don't want to be in the business of developing products and devices. They want us to alleviate the burden of issue of health connectivity. As we talked about, I think the big theme for the next while is integration. If we can have integrated programs, we can have really meaningful results. And for us, being able to deliver on our platform integrated devices in a very seamless, easy fashion for patients to start using them by themselves. Having the data seamlessly be incorporated into the health record for the institution to see the data. Most importantly, having the clinical productivity suite for the nurses and case managers to use that real-time health information in a very meaningful way and to deploy a strategy where for Vidant they've saved almost $5 million in a span of a few months with patients just using the products on the program for a short period of time. When you start constructing and building upon that, other conditions, longer-term use of the system, which we have in some other locations, it gets quite exciting. And why we all get up every morning, I think, is because of patients like Mr. Tyson, where we were assisting and saving his life. We were one piece of the puzzle. The technology component is one piece of the puzzle. I think really what is wrapped around as far as the clinical service is a very important part that the hospital staff delivers as well, or third parties. We've integrated with MD Live because, I mean, you have an opportunity now to alleviate the staff burden with regards to overcrowding through a wonderful physician network where it's really for us about healthcare on demand, where I would like to be in touch with a group, but we can empower MD Live to remotely be exposed to the data that they need to make the right decisions for individuals. So.
Chuck, speaking of sort of physicians on demand, how do patients typically respond to a physician that they've really never built a relationship with, and they find themselves with a clinical problem of some sort? And most, I think, patients at some level do some kind of study, or they look for a referral. They do something to try to have some sense of knowledge about the doctor they're going to encounter. What are your thoughts about basically having really no choice, if you will, as to what physician you'll encounter coming through a portal such as MD Live?
Yeah, Pierre, when we think of our business, adoption 3 years ago was very low. And now we're up to about 300 to 400 medical consultations per day. So when we think about our business, we relate it to ATM banking in the 1980s. People see the machine in the wall. They see people using it, but they're cautious. They don't know if they should stick that piece of plastic in or put money in it. And now we know where we are today. From the exhibit hall downstairs 1 hour ago, I transferred money into my college-age son's bank account using a third-party mobile app that was just released 6 months ago. So we think about where ATM banking has gone and where financial services are now. We believe that telehealth will become as ubiquitous a part of your healthcare paradigm as having a physical or taking Anacin when you have a headache. It'll just be automatic. I agree so much with what both Amy and Aidan said. So much about the evolution of this product is the change management of the physicians. Physicians 3 years ago would say, no, I don't think I can diagnose a UTI over the phone. And now with academic opinion from so many of our partners like UPMC and Harvard, we're able to say, with complete confidence that we have the protocols to help those patients and to communicate with them along the way that this is safe and secure. And if there's any question that you should have face-to-face services, we'll make that referral happen right away.
Aidan, maybe you and Chuck both could comment a little bit on sort of the privacy and security protocols that you expect to be in place with sort of portals of communication such as this. And I think generally the patients make a presumption of privacy and security, but obviously underlying that is a fair amount of effort on your behalf to actually, obviously assure that the data is secured. Can you comment at all on the efforts to secure the data?
Well, most of our work regarding privacy is through the development process. So in that we have to go out and we have to run trials and we have to do validations, and we do endless research on particular devices, most of our privacy is through that development process. Now, within on the software side, there are endless walls that are being put up in order to have some level of control of privacy, but a lot of the devices that we do that are wirelessly enabled are closed loop. So they're not talking specifically. We have a little device that controls your bladder. It could do it quite easily through your smartphone, but instead there is a separate fob that you essentially turn your bladder on and off with, which is quite handy. But that's a closed loop system. So it is only speaking in its own protocol between those two devices. And that's mostly on the medical side, how they're dealing with privacy. That will change, I think, as it goes forward. This is where you mentioned the FDA changing. The FDA is motoring forward and understanding what these lines and limits should be.
You know, while you're, to go a little bit deeper there, is what are your thoughts about the early stage companies partnering relatively early with academic medical centers? Do you think that there's significant value in basically finding sort of like-minded academic partners, or do you think it's perhaps, if you will, takes them down into the direction of being a device development, a more complicated regulatory pathway as they partner with an academic center?
Well, we work with a bunch of different academic centers. And I think at the end of the day, if there is the spark of a good idea, taking that sort of fail-fast idea, before you go out and develop a medical product, you should find out whether it has some value. And there are very good methods to do that are tried and tested. And I think the industry has changed significantly over the last few years, where the ability to come up with an idea, test a technology out of MIT or Harvard or wherever the local schools are, and or partners, which is close to us in Boston. But to test it, validate it, build a business case, look at the reimbursement structure, understand the IP landscape. There's a whole bunch of things that one can assess before you get into what is the big money of developing the technology. You've got to know that there's a there first. Sure.
So we have a few moments that are left over for questions. If there are any questions at all, I think it's an opportunity to speak to four experts really about the development process, and we'd be certainly happy to field any questions that might come from the audience.
It's like we're suntanning under these lights.
David Wilcox, Reach Scale. At the mHealth Summit, the technology leader for Intel gave a keynote speech. He had not attended the previous summit because he almost died. And oddly enough, after surviving that kind of thing, you would not expect him to have said the following thing. He said he was dedicated to eliminating the need for physical hospitals. So I'm curious about how you gentlemen and lady feel about that kind of position being taken at a conference that probably had 2,000 people in the room when he said it from all over the medical industry.
Well, many of our clients are hospital healthcare organizations, and one of the common things that they're saying nowadays is they want more clicks and fewer bricks. Most of the hospitals do not want to break ground on new construction and start building new facilities. They want greater efficiency. They want to use technology to reach more people outside of the four walls and to bring healthcare into the home. So I think Jason's company and our company empower that. We augment home care, device integration, and the ability to understand one's biometric measures, whether you're chronically ill or whether you're hypertensive. is very valuable. But certainly, there's a lot to be said about having quick access to care. We're not for people who are in crisis, but we had somebody, a patient who was heading to Newark to get on an international flight to Europe, believed he had angina. He had had angina in the past. When he drank too much coffee, he had chest pains. His wife thought it was different this time, and there was something that motivated her to contact us and to reach out to him in his car as he was driving to Newark. And we, after a 40-minute consultation, advised him to go immediately to the emergency room, where it was determined that he was infarcting, he was having a heart attack. So again, there's a lot to be said for that, but I think certainly, hospitals serve a very important need. It's just how we utilize those services, which is going to be so critical economically and from an access and volume standpoint going forward.
I think we're a long way from the plumbing and carpentry of a hospital services to be eliminated. So it'll be done in different ways. But if you understand and see the sophistication of the big medical companies in how they are rethinking how they do their business, there will be structures in place for a long time. But I don't think they aren't building the way they did, but they're building differently.
The vision. Oh, sorry.
No, go right ahead.
Yeah, the vision is inspirational, though. I mean, you have people who need care, you have people who can provide it, and you have distributed, locations, and you have the technology that can connect them. Hospitals, everybody says, oh, it's sick care, it's not health care, and we need to integrate prevention, and we need to get ahead of things so that people aren't showing up in the ER. We're sort of ahead of it. So as we get more programmatic, and as we look at treating the person and treating the condition, and not just treating them when they come in, I think that's going to benefit everybody. So to kind of put a line in the sand and say, oh yeah, this is where we're heading, maybe that will push us a little farther.
Sure.
And actually, maybe to just continue that thought, I think it, and what Aidan and Chuck mentioned, really about the transformation that's happening is really more around collaborative type of opportunities where different types of organizations are now working together to, again, reap more efficiencies out of the system and do innovative things. Again, I think, healthcare facilities like hospitals serve a very deep purpose. And again, a lot of the experts there have knowledge that we can transfer out and create environments of more efficiencies. I mean, something that we've taken a lot more focus on over the last couple of years have been more of our strategic partnerships that we've been working on together. One very exciting one is with ADT. And believe it or not, ADT has a business now around ADT Health. And when you think about it, delivering solutions around lifestyle monitoring and management, when we think about opportunities in independent living, what we have started to do was merging our expertise in clinical monitoring surveillance with now lifestyle monitoring and managing. And you start to think about the opportunities where hospital systems can now deploy their expertise, communicate. A wonderful network can now remotely communicate with individuals and leverage the power of all these technologies with a group like ADT Health now. And you should definitely come see some things that are happening in South Hall at ADT as well.
Great. I'd like to thank all the panel. Sorry, there's one more question in the back. Go right ahead.
Okay. Right here. Hi, my name is Bobby Tishow. So this is obviously a good direction we need to head. There's a lot of value to it. What would you advise as a panel on how do you get there? What are some of those next steps? What can your companies provide that would help providers and health systems actually get there?
One thing that it points to your question and also your question, hospitals are evolving, they're changing. We recently worked with Joslin Diabetes Center. They have a well-established in-clinic diabetic weight loss program that transforms people's lives, and the clinical outcomes are great. They said, that's great for the Boston area, but we want to help diabetics across the country lose weight and manage their condition. So took everything they knew about training and fitness and nutrition and clinical interventions and social support that was experienced in the live clinical environment. How do we make that into a digital tool and extend that? So I think it's really understanding who are the people we're trying to serve, what are their needs, what are their unmet needs, what are their obstacles, what is the value they're trying to derive, and how do we build our organization, products, services, interfaces to help those people across channels.
I think we're going there by default, and whether we're driven by costs, hospitals, insurance companies, patients, providers, everybody has the same interests. And while in the way the U.S. system is set up is not 100% tidy, it is highly entrepreneurial, and so there is a rush going on to make large changes, little changes, but there are changes going on everywhere. There's going to be a lot of fallout through that process because there will only be so many winners. But it is, it's already in play, and the level of innovation that we see going through the system is huge.
I just want to make one comment. I disagree a little bit. I think we have to think about how we can accelerate this adoption and make things happen a little bit in a more accelerated fashion. And I think one area that I would definitely point out, and it's been very successful for us, although we're pretty mature now as a company, we've been in the space, I think, for already well over a decade, 13, 14 years. But if you're really passionate, you believe around your technology or program or service, you have to be very open around, because I think the key is around financial incentives. One of the comments in the last panel was with hospitals and healthcare, they're the last to jump on the bandwagon. If you think about last to adopt technology, here you have hospital systems that are now about 1.5 years already into a process where the government is financially penalizing them. And they're still thinking about, should I do something about this problem where I'm losing money at the end of the day? I think that you have to be very open, and if you're passionate about being able to deliver a service and working with your end customers around the business models, think about innovative approaches to the financial model as far as risk sharing, and being open to being wrong when you first think as around your hypothesis as far as what the economic model might be, and working as a guide and partner with the institution as you ask the question.
And try really hard, too.
Yeah. That's a good note to end on. Thank you very much for each of you having spent the time today. Thank you.
Thank you, everyone.